Hello everyone, I'm Easy Peasy Medic here. Welcome back to another part of bleeding disorder, that is vascular disorder. Vascular disorders are the abnormality in vessels or perivascular connective tissues. Examples of vascular disorder are Hino-Schönlein-Purpura and Ehlers-Danlos syndrome, infection like meningitis, and steroid drugs. In today's topic, I'll be talking more about Hino-Schönlein-Purpura to you all. Without further ado, let's look into Hino-Schönlein-Purpura. It is vasculitis of unknown etiology characterized by the inflammation of small vessels associated with leukocyte infiltration of tissue, hemorrhage, and ischemia. The immune complexes associated with Hino-Schönlein-Purpura are mainly composed of IgA. It usually has preceding upper respiratory tract infection. Hino-Schönlein-Purpura is the most common systemic vasculitis of childhood and cause of non-thrombocytopenic purpura, with an incidence of 13 per 100,000 children. It occurs primarily in children 3 to 15 years of age, although it has been described in adults. Hino-Schönlein-Purpura is slightly more common in boys than girls and occurs more frequently in the winter than in the summer months. Hino-Schönlein-Purpura is mainly characterized by rash, arthritis or arthralgia, and less frequently abdominal pain and hematuria as the first symptoms. The hallmark of Hino-Schönlein-Purpura is palpable purpura, caused by small vessel inflammation in the skin leading to extravasation of blood into the surrounding tissue, frequently with IgA deposition. The rash is classically found below the waist, on the buttocks, and lower extremities. Arthritis occurs in 80% of patients with Hino-Schönlein-Purpura and is most common in the lower extremities, particularly the ankles and knees. The arthritis is acute and very painful with refusal to bear weight. Abdominal pain is typically noted during acute phase of the illness and it occurs in about one-half of affected children. It most typically presents as mild to moderate colicky abdominal pain, thought to be due to small vessel involvement of the gastrointestinal tract leading to ischemia. Less commonly, significant abdominal distension, bloody diarrhea, intersubsection or abdominal perforation occurs and require emergent intervention. One-third of children with Hino-Schönlein-Purpura develop renal involvement, which can be acute or chronic. Although renal involvement is mild in most cases, acute glomerulonephritis manifested by hematuria, hypertension, or acute renal failure can occur. The rash also can be accompanied by edema, particularly of the calves and dorsum of the feet. Hino-Schönlein-Purpura occasionally is associated with encephalopathy, pancreatitis, and orchitis. Pancreatitis is the inflammation of the pancreas, whereas orchitis is the inflammation of the testicle. In patients with Hino-Schönlein-Purpura, inflammatory markers such as erythrocyte sedimentation rate and C-reactive protein are elevated. In full blood count, there is leukocytosis, meaning the white blood cell count is elevated. The platelet count is the most important test because Hino-Schönlein-Purpura is characterized by non-thrombocytopenic purpura with a normal or even high platelet count. Therefore, differentiating Hino-Schönlein-Purpura from other causes of purpura that are associated with thrombocytopenia such as autoimmune thrombocytopenia, systemic lupus erythematosus or leukemia as per mentioned in the previous video. Next, urinalysis is performed to assess hematuria, meaning blood in the urine. Blood urea and serum electrolyte is to evaluate renal function. Stool for blood is to look for evidence of gut ischemia, and last but not least, abdominal X-ray is to assess if there is any gut perforation. Treatment for Hino-Schönlein-Purpura is supportive. A short-term course of non-steroidal anti-inflammatory drugs, NSAID, can be administered to treat acute arthritis. Systemic corticosteroids usually are reserved for children with gastrointestinal disease and provide significant relief of abdominal pain. A typical dosing regimen is prednisolone for about 1 to 2 weeks, followed by a tapered schedule. Acute nephritis typically is treated with corticosteroid but may require more aggressive immunosuppressive therapy. The prognosis of henoch-Schönlein purpura is excellent. Most children have complete resolution of the illness without any significant complication. However, patients with henoch-Schönlein purpura renal disease are at highest risk of long-term complications such as hypertension or renal insufficiency, as there are elevated blood urea nitrogen and persistent high-grade proteinuria. Moving on to its complication, most cases of henoch-Schönlein purpura are monophases, lasting 3 to 4 weeks and then resolving completely. The rash can wax and wane. However, for 1 year after henoch-Schönlein purpura, parents should be warned regarding possible recurrences. The arthritis of henoch-Schönlein purpura does not leave any permanent joint damage. It does not typically recur. Gastrointestinal involvement can lead to temporarily abnormal peristalsis that poses a risk of intersubsection, which may be followed by complete obstruction or infection with bowel perforation. Any child with a recent history of henoch-Schönlein purpura who present with acute abdominal pain, constipation, or diarrhea should be evaluated for intersubsection. Furthermore, renal involvement rarely may lead to renal failure.
Thank you for watching and lending me your ears. Please like and share my videos as well as subscribe to my channel. I will see you in my next videos. Bye!